All right, I think we can get started. I know we're going to have some more folks trickling in, but thank you, everyone. Welcome to CR Unite 2020. My name is Karen Parisi, and I'm the Senior Vice President of Marketing here at Central Reach. On behalf of the entire Central Reach team, thank you for spending these next 2 days with us to learn, hopefully share ideas, and also, most importantly, please do network with one another. We do have a community section on the app if you haven't checked it out already, where you can interact with one another or ask questions and hopefully learn some new things. So also quick thank you to our sponsor, Change Healthcare, for sponsoring this session. Lastly, we have 2 quick announcements to make. If you missed the CEO welcome session, we have announced that CR Unite 2021 is coming next year to San Diego on October 25th through the 28th. So hopefully we'll get to meet you all in person next year. And then lastly, housekeeping items for today's session. So there will be time for some Q&A at the end. So please, we ask that you feel free to, add your questions to the chat, and I'll try to answer, or I'll try to ask your questions at the end. So thank you so much again. And without further ado, I'd like to introduce you all to our keynote speaker, Dr. Steve Marin. Thanks, Steve, so much for joining us today.
Thank you all for being here, and thanks for having me, Karen. I really appreciate the chance to kind of share some of my thoughts on behavior analysis. I don't know whether you're going to get to see me, so I'll do a quick hi, but I'm going to share my screen and let's get right into it today. Give me a second to get the slide deck up and running. So the question at hand is really, is behavior analysis a healthcare discipline? And this is not the first time this issue has been raised. I'll talk a little bit about the history of this issue in your profession. But before we really go much further, I want to give you a sense of my perspective that I'm taking here. First of all, I'm not a behavior analyst. I don't play one on TV, and according to the Behavior Analytics Certification Board, I'm not even qualified to take the exam to become a behavior analyst. I trained as a pediatrician. I've been involved with children with special needs for decades. I launched the first 0 to 3 early intervention program in the early childhood system in New York City back in the 80s. I've worked for 2 insurance companies, Aetna and Centene. I've been the chief medical officer of a national primary care practice. I've been a hospital executive. And more importantly for this conversation is I spent almost 4 years as the chief medical officer at Centria Autism Services, where I really had an opportunity, again, to be an ex officio member of the behavior analytic community. My role today is to kind of reflect back some of the things I've observed and come to understand about behavior analysis. I think if there were any way I'd like you to take my talk today, I'd like you to take it with me in many ways, serving in a very classic sense as a clown. Not a white face, go to the circus clown, but a clown as someone who exaggerates the things they observe in the world around them for both entertainment and hopefully some insight into their observations of the behavior of others around them. This is not in any way meant to in any way criticize the profession. I am equally critical, however, of my own profession. You can see here on the screen, I've just given a snippet of some articles I've written where I provide the same perspective on my own profession. Also, I want to acknowledge the fact that this work, the work that I'm about to discuss, is already being done in your profession. I want to acknowledge the commitment and the activity, particularly of the Association for Professional Behavior Analysts, ABPA, and CASP, the Council for Autism Services Providers, both of whom have taken serious and sophisticated views of the issue of behavior analysts as a profession and a discipline. But remember, there's a little bit of exaggeration today, so bear with me because it's exaggeration for effect. But let's jump right into it, because the question really is, should behavior analysis be a healthcare discipline? And I want to talk for a second about why I use the word discipline, because in fact, you can be a healthcare discipline and still maintain your professional integrity. Nursing, for example, is a healthcare discipline that maintains an independent professional integrity and identity. Pharmacy is a healthcare discipline that maintains an independent professional identity. So I want to differentiate between behavior analysis as a profession and behavior analysis as a healthcare discipline, because really, I believe that behavior analysis should be a healthcare discipline because it is necessary. And it's necessary for two reasons. Number one, it's necessary for society for behavior analysis to be a healthcare discipline. And I believe it's necessary for the profession. And again, I'm speaking as an observer here. It's a belief I have, and I hope to share with you the why over the course of this presentation. So let's jump in. Why is it necessary for society that behavior analysis be a healthcare discipline? Well, it turns out that 50 to 60% of health outcomes and longevity are associated with behavior and environment, not medical care. And this finding comes from the medical community. Articles in the New England Journal of Medicine, articles from the National Academy of Medicine note that medical care is established to account for only 10 to 20% of modifiable contributors to healthy outcomes. The other 80 to 90% is health-related behaviors, socioeconomic factors, and environment. So when we take this apart, when we unpack this a little bit, what are the behaviors and the environmental factors that they're talking about here? Well, for behavioral factors, clearly they're talking about behavioral health conditions, anxiety, depression, obsessive compulsive disorder, autism spectrum disorder. We're also talking about health-related behaviors, the kinds of things we do to sustain our own health and integrity. And we're also talking about functional status in the community, what medicine calls activities of daily living or independent activities of daily living. On the social factors and environment side, we're looking at safety behaviors and the capacity for learning and the sense of community and how people interact with each other in community. And when we take these as the factors that affect health outcomes and longevity, the question then becomes, how can behavior analysis contribute to these? The fact of the matter is, there is a massive body of literature and research on the contribution behavior analysis can make to the management of primary behavioral health conditions, to medical condition management, including the acceptance and commitment to plans of care, medication compliance for a host of chronic conditions, health-related behaviors like sleep and dental health and fitness and substance abuse and safety. In public health, I'm often embarrassed of the fact that the public health community doesn't use standard acceleration charts to chart the frequency of events in communities. I want to acknowledge the work of Stuart Harder and a whole team of behavior analysts who have been using standard acceleration charts to track the frequency of COVID. There's an amazing Facebook group where this is being done. And unfortunately, the public health community knows very little about this approach to looking at frequency distributions. Education, employment, communication, social interaction, these are all places where there's a body of evidence about the potential for behavior analysis to make a dramatic contribution to these areas of behavior and environment that can help improve the health of individuals and communities. Now, I'm not the first person to come up with this. This has been discussed in your literature since 1993, as far as I can tell, when Keith Allen and the group at the Meyer Rehabilitation Institute talked about the need for a relationship between applied behavior analysis and pediatrics. This was well before we saw the emergence of the autism care system. Pat Freeman at Boys Town spoke in the early 2000s about the importance for integration of behavior analysis with medical primary care. You can see this has come up within your discipline as a potential. And yet, as you can see in some of these, it's not a new proposal, but it also has not been realized. And we're going to talk a little bit today about some of the barriers to realizing this potential objective from within your own discipline. One of the big areas where there's a challenge is where things are published. And this is a problem with academic niches across the board. This isn't just a problem with behavior analysis and medicine, but when you've got academic niches, disciplinary niches, it becomes very difficult to make the decision as to where to publish. Do you publish in your own journal, or do you publish in the journal that for a discipline that may benefit from the work you're doing? And nowhere is this more obvious than in an article that was published just last month in the Journal of Applied Behavior Analysis on behavioral strategies for reducing disease transmission. I desperately wish this article had been published in the public health literature. I think it would have made a significant contribution to some of the issues that we're having in terms of managing today's pandemic. You know, that establishes why behavior analysis becoming a healthcare discipline is necessary for society. But the bigger issue is why I believe this is necessary for the profession. And I think it's the statement I want to make is I believe that ensuring full recognition for the value of behavior analysis really will require behavioral analysis to be fully integrated into the healthcare ecosystem. And again, this isn't about giving up the professional identity or the integrity of the profession, but it's about being part of this broader ecosystem. And we've seen some of this happen with the evolution of the autism care system. And I call it the autism care system because in many ways, it's really a third space outside of healthcare and education. And in fact, it has in many ways been of great benefit to the profession, but at the same time, it's posed some challenges. And again, this isn't coming from me, this is coming from your own literature as to how the focus and of behavior analysis and autism, or the alignment of behavior analysis and autism, has caused both opportunity as well as some challenges for the profession. The opportunity, obviously, fueling rapid growth and a whole new economic base. How behavior analysts got paid changed when the legislative reform required insurance companies or required states to provide behavior analytic services to children with autism spectrum disorder. The challenges, however, are this was not something that evolved and planned from the behavior analytic profession. This was something that in many ways what happened externally. And I'm going to talk about that in a couple of minutes. And remember, there's some deliberate exaggeration here as part of our effort to make the point. The other challenge is that for a good part of the population that's not familiar with behavior analysis, ABA and ASD are inextricably linked. And to some, ABA is only for ASD, and they don't understand the depth of the literature that we just discussed. There are some challenges in terms of training and qualifications of practitioners, and having been one of the executives responsible for the design of the onboarding program at Centria, I can tell you that we've all heard the trope that 80% of current behavior analysis have all been trained in the last 5 years. It's a relatively early profession in terms of its professional life cycle. There's been some demands on the profession to create more behavior analysts, and I think that has put some stress and strain on the training and qualification process. I can tell you that there was a time in medicine where we go through a rotating system of training where we don't work in one discipline, we work in multiple disciplines, anywhere from 500 to 2,000 hours at a time over 7 or 10 cycles of different disciplines, OBGYN and cardiology and others, so that when we come out, we've got a balanced training. I think the practicum focus on autism only has caused some challenges in terms of people having a full breadth of understanding of what behavioral analysis can do. I think there are some issues in terms of in the ecosystem, respect for the discipline, some challenges to professional identity. And what's the role of behavior analysis in the broader ecosystem? And these are not questions I can answer. These are questions I'm posing to be considered by the community at large. I want to look through this through the lens of evolutionary ecology, which, by the way, is about how species respond to their environment. So in many ways, evolutionary ecology really is grounded in some basic principles of behavior analysis. From my outsider's perspective, having worked throughout the entire healthcare ecosystem, in managed care, insurance, in hospital systems, in primary care and public health, behavior analysis is a niche and its own niche in the ecosystem. And when you understand the ecological niches, it's not just about the habitat you're in, the protected space you're in, but the way you interact with other species, the role the species plays in the ecosystem. The perception right now is the role the species play is in the healthcare ecosystem is specifically to autism spectrum disorder. And the fact is, this in many ways has become a trap for behavior analysis in its niche. However, I also want to say, as an outside observer, I think that sometimes the function of behavior of the profession is to sustain the niche. And there's something that is considered protective. Niche species, not just behavior analysis, but niche species in general, stay in their niche as a way of self-protection. So let's take a look at how ecosystems evolve and change and what they're how they're comprised. And so we've got a healthcare ecosystem, we've got a behavioral mental health ecosystem, we've got an education ecosystem, and these are all overlapping. The dotted lines means there's some free movement among them all, and I'm going to take a look at these ecosystems around the year 2000. So let's not get specific about where special ed happens to be and the fact that psychology overlaps. The idea here is to illustrate how changes occur and where behavior analysis fit around the year 2000, again, as an outside observer. So to me, around the year 2000 and before, behavior analysis was a niche peripherally related to the behavioral mental health ecosystem and the education ecosystem. Near psychology, near special ed, kind of near the autism community. And then what happened was the autism community imposed a force on the policy community. And the policy community then imposed its own force legislatively, which changed the behavior of payers, which then in turn reflected back on the behavior of the behavior analytic community and caused it to grow. And it caused it to grow and integrate a little bit more with payers, not always to everybody's happiness, and a little bit more with the autism community to their happiness. And this, again, sustained behavior analysis as a niche to certain extents. It protected the species of behavior analysis, but expanded their role and place as a niche in the broader ecosystems. There are consequences, however, of being a niche, because successful ecosystems depend on diversity, collaboration, and competition for their success. And I want to go through again my analysis of some of the consequences to behavior analysis of sustaining themselves as a niche ecosystem. The first is that other species can marginalize your role in the ecosystem. This is a discussion paper from the National Academy of Medicine that was published in 2019, actually. It's called Workforce Development to Enhance the Cognitive, Affective, and Behavioral Health of Children and Youth. And nowhere in this paper, or again, a subsequent version of it that was published in 2019, is behavior analysis mentioned. Nowhere. In a National Academy of Medicine report on workforce development on behavioral health of children, behavior analysis is missing from the report. I took the liberty of reaching out to Dr. Thomas Boat, who you see there as the first author. Dr. Boat was the dean of the University of Cincinnati School of Medicine. He's a pediatrician by training. He was the chairman of the Department of Pediatrics at the University of Cincinnati. And I wrote him a very long and extensive note that explained behavior analysis, explained the role of behavior analysts, explained the certification of behavior analysts. And this is what I got back from Dr. Boat. I understand that there are certificate programs and there's a certification mechanism. ABA, in my mind, does not qualify as a discipline. For that reason, it was never considered for deliberations at our National Academy workshop and related publications. This one person chose to marginalize an entire profession and had the authority to marginalize an entire profession in a National Academy of Medicine report on behavioral health of children. That's what I mean when I say you're at risk when you're in a niche of other people marginalizing who you are. The second risk of being in a niche is the expectation of ecological convergence, which is, again, an evolutionary ecology term that when unrelated species evolve similar features, the expectation that you will start to act and look and think like them. This is the Magellan Healthcare Guidelines from 2017. I chose it for effect. It may have been updated, although I don't think it's much different. And the key here is to look at what they want you to treat: deficits, impairments, and prevention of harm. Medicine focuses on pathology. We want to look for things that went wrong and then we fix them. If something isn't wrong, then we don't intervene, because in effect, health is considered the absence of disease. So when behavior analysis is treated in the healthcare system without being an integral part of the healthcare ecosystem, you are now at other people's mercy in terms of the areas that you are expected, how you're expected to perform. Now, I happen to know that behavior analysis does more than just treat deficits, impairments, and harms. But the fact is, this is the way that you will be judged, because ecosystems look for where you fit, and fit is determined by the degree to which you reflect similar behaviors or phenotypic features in the ecosystem. Another place where there is a risk of being a niche is being judged by other species criteria for fitness. This happens to be Aetna's Clinical Policy Bulletin, written in 2002, last reviewed in 2020. And you will note the yellow where it says, review and meta-analysis found inadequate evidence that applied behavior intervention programs have better outcome than standard care. I don't know what standard care is. The authors concluded that inadequate evidence that applied behavioral interventions have better outcomes than standard care. But the fact of the matter is, this does not mean that Aetna will not provide services where there is legislative mandates, but this gives them an out when they don't have to. So they are judging based upon what they consider to be the criteria, which in this case is randomized controlled clinical trials. The same tools they use, the same evaluation they take for pharmaceuticals and medical devices, and surgical procedures, they use to evaluate the research and the literature in the behavior analytic literature. And when they do that, they're not actually using the research methodologies that were the basis of the research in the first place. They're using criteria for other species to evaluate your discipline. And this raises an important issue about, should randomized controlled trials even be the basis upon which ABA is judged? And it's very interesting, because if you look at some of the consistent references that are used by insurance companies to evaluate the evidence, particularly they use the Cochrane review, which again is totally dependent on randomized controlled trials. They ignore the fact that even in medicine, the idea of N of 1 trials is very much aligned with the behavior analytic research methodology, and yet it's ignored when there's no behavior analyst there to remind them that the species is being judged on criteria for fitness that is not consistent with the ecosystem that they came from. The interesting quote here: aggregated results of many N of 1 trials, all carried out the same way, will offer information about how to better treat subsets of the population or even the population at large. And what they're talking about here is the use of genomic tests to make medication decisions. But the fact of the matter is, all of the legislative reform that resulted in ABA mandates in 50 states in the union were based on this very same principle. Many N of 1 trials, all carried out the same way, offered better information about how to treat a subset of the population, children with autism spectrum disorder. So, you know, this randomized controlled trial thing gets more complicated when other species are shaping your environment and controlling your message. These are two articles that were published in pediatric literature. One just this week in JAMA Pediatrics, the other about a year and a half ago in the journal Pediatrics from the American Academy of Pediatrics. And in both of them, they talk about randomized controlled trials for something called a naturalistic developmental behavioral intervention, an NDBI. Now, to me, in my understanding, is that ABA, applied behavior analysis, is not a form of therapy, but a set of principles upon which therapies, plural, are based. So to me, pivotal response treatment is an application of the principles of ABA in a particular therapeutic model. Both of these articles in the pediatric literature essentially differentiate PRT from ABA, and they put them into this new category called naturalistic developmental behavioral interventions. Now, you in behavior analysis may say, oh, well, that's, we know what that is. But the fact of the matter is the pediatric community doesn't. So this is how they're being introduced to ABA in a terminology that is now differentiating ABA from NDBIs. The other risk when other people control your message is that the insurance companies, and remember I worked for 2 of them, could now come along and say, we use randomized controlled trials to judge the quality of evidence. There's randomized controlled trials for NDBIs, but there's not randomized controlled trials for ABA. So we're going to pay for NDBIs, and we're going to start to deny treatment for ABA. That's a logic that is absolutely probable or possible, given the fact that behavior analysis is not part of the healthcare ecosystem. So you have to understand ecosystem behavior. Ecosystems kind of grow in complexity until they become something called the climax community. It's a reference to their maturity. And climax communities are really a function of how the species adapt to their interactions with each other. The ecosystem itself selects the species that succeed based on their fit. And in this way, climax communities can resist change because the interaction between the members of the community are so interrelated that it prevents admission of new species. And in healthcare, this is happening right now. The American Medical Association has successfully prevented CMS from allowing non-physicians, physical therapists, to perform inpatient rehab services. And they promote this. This was on my Facebook feed. They promote this with a level of pride. But to me, all this is the resistance to change and sustaining equilibrium for, again, this idea that physicians in many ways are in fact the arbiters, the final arbiters of what is an appropriate form of therapy. And this is, again, another compelling reason to have a place at the table in the healthcare ecosystem for behavior analysis. I want to acknowledge the remarkable achievement of the ABA Coding Coalition, because in fact, they have made a really important step towards meeting this fitness criteria through their work to create and generate CPT codes for behavior analysis. And I have personally submitted a CPT code application. I've personally been at the big AMA meeting, and this accomplishment cannot be underestimated. My application for a CPT code for coding for adverse drug reactions, which I don't understand how anyone would counter that, did not make it, but the ABA Coding Coalition was able to get your codes in place. And not only that, the ABA CPT codes are diagnosis agnostic. They're not about autism. They're about behavior analysis. And this is really the first step to me towards behavior analysis achieving its goal of saving the world. However, in the healthcare ecosystem, just because you have the code doesn't mean you're getting in the club. It's necessary, but not sufficient to get into the club. You need to understand the functions in the ecosystem. And there are a number of functions. I'm not going to go through these for you, but we have a basic science function, we have a pathology function, we have signs symptoms function, we have diagnostic function. And I give an example here about microbiology, the basic science of microbiology, ultimately provoking and stimulating the study of infectious disease and how that gets applied to a particular problem and how therapeutic strategies are developed and how the species interact, how different roles in the ecosystem interact, how care is organized around the habitat and how operations are managed. And I want to talk for a second about this last element here, prior auth and medical necessity, because this is a place where all of the disciplines in the healthcare ecosystem share. And I know for many of you in behavior analysis, this idea of medical necessity was an entirely new demand and to try to understand what this meant. But the fact of the matter is, we in medicine have been dealing with this for decades. You cannot walk into Home Depot and name your own price for a refrigerator, but healthcare payers regularly reduce or deny payments even after services are rendered. Notice the word reimbursement. It means we've already shelled out, we've already paid our staff, we've already covered all our bases, and now we're asking to be reimbursed. And we often don't get completely reimbursed for the services because of this issue of medical necessity, which pits professional judgment against insurance company coverage. And this is a genuine phenomenon across all members of the healthcare ecosystem. And in fact, have resulted in serious challenges and risks to health when insurance companies denied, for example, in the example here, denied a bone marrow transplant to an 8-year-old child with cancer because they kept explicitly calling it an experimental procedure. Again, back to that Aetna clinical coverage document. Medical necessity is a legal doctrine. The fact that a provider prescribes or recommends something does not automatically make it medically necessary. Payers have their own rules for coverage determination. And this is all the more reason why it's in the best interest of behavior analysis to build professional bridges into the healthcare ecosystem, both in terms of increasing ABA literacy and differentiate the therapy in the minds of all the disciplines in the ecosystem, to demonstrate shared purpose of the profession of behavior analysis with other members of the healthcare ecosystem, and illustrate the value proposition for ABA in healthcare, and finally to get allies to support appropriate criteria. In the state of California, for example, any child, there's a program called EPSDT. It's an early screening and diagnostic tool for children on Medicaid. It's a mandate, but in California, behavioral health therapy services, ABA, can be considered medically necessary for any condition under the EPSDT program. And this is, but the medical necessity determination there is made by the physician, not by the behavior analyst. So this is, again, one of the reasons why these bridges become so critically important. You know, the challenge always is the challenge of collaboration, and you know, collaboration is not a defined discipline in healthcare. As a matter of fact, just because everybody's sitting at the table doesn't actually mean they're collaborating. There's a difference. And the idea is to find these mutually beneficial elements where disciplines and professions can work towards common goals, but there's some sharing that ultimately will result in a sense of a loss of autonomy or habitat. And I use the word turf here, but we're really back to the issue of habitat, because that's really what happens in ecosystems, is how do you control your habitat? And to some extent, as I said, being a niche allows you to control your habitat and have that sense of stability and autonomy. But in fact, as we've seen, there are significant consequences to maintaining that niche. You know, there are a number of factors that influence collaborative success. The climate, the members of the group themselves. This might require some critical examination of the function of certain behaviors in your profession. It requires some activities among the members of the collaborative in terms of mutual understanding and respect. This has to be built, it's not automatic. There's obviously the need to compromise. Members need to share a stake. And I genuinely believe that with the work that's being done right now on that 50 to 60% of outcomes, as we're moving more into a value-based care system where healthcare medical professionals are being incentivized and compensated based upon outcomes, the fact that behavior analysis can offer the medical community some very powerful tools for achieving goals that they're struggling with really becomes an important trigger for the level of collaboration that's required. But it does require change on both sides' part. There's new habitats that you're going to have to learn to survive in. There's managing diversity issues, diversity of opinion. I began this by saying I actually trained in addition to my training in pediatrics, I spent 3 years training in psychoanalytic psychotherapy. There's an amazing body of literature about the relationship between Sigmund Freud and B.F. Skinner that I've come to understand. But you know, understanding the perspectives and the models of care of other disciplines in the habitat is going to be critically important. Something called nutrient cycling, which is where you actually give up certain elements and factors that are then used by others in the system. And a couple of examples here, you may need to adjust your vocabulary to ensure understanding. I'm fond of saying, I want my child to mand, said no parent ever. So it may require some adjustments in the profession to understand how you communicate what you do. Aligning standards of practice and professionalism wherever possible. Most of the healthcare disciplines have ethical standards. There's value in collaboration around some of those standards to build connection. You need to earn your professional equity. It doesn't happen automatically. You need to demonstrate the value of the discipline. And again, as we saw in some of the conversations about, in this prior slide, on the nature of collaborative success, selective accommodation and compromise really becomes critical. And this does in fact change the discipline. And we've seen this, I can tell you, we've seen this in pediatrics, less so in primary care medicine, certainly less so on the surgical side. But with the changes in payment reform in healthcare, you're seeing more and more of even the medical professions taking this approach. A great example of a new habitat is the emergence of urgent care. Urgent care came because the medical community did not respond to changes in its environment. Remember the environment that they lived in. There was social change that resulted in people requiring care during, quote, off hours. The medical community did not respond to that need, and other species stepped in to meet the needs of members of the ecosystem. And the emergence of urgent care became, at some point, in many ways, a threat to traditional medical practice. And this is a new habitat. When we do this collaborative work, there's a number of things that need to be considered as the collaborations proceed. And we tend to think about our relationship with patients and caregivers and facilities in terms of our role in the ecosystem. And there's an alignment between role-based functions and the goals that we want to achieve. But in fact, as we move to collaborate, there's additional functions which are team-based functions. We have our role-based functions based on our profession. We have team-based functions based on the disciplines in the ecosystem. And with that, there's interactions that occur based upon where you are. If you're performing a goal-based tactical interaction, then both role-based functions and team-based functions have to focus on tactics towards goal. If you're focused on team-based functions, then role-based functions and team-based functions have to work on governance-related interactions. And we need to separate these because you wouldn't, for example, in the middle of a soccer game, stop to argue with your teammate with the ball in play. And that's it. If you have an off the field issue, you don't bring it on the field with you. So governance interactions and tactical interactions need to be managed independently, and they need to be addressed independently so that role-based functions and team-based functions can happen in a very collaborative and goal-directed manner for the ultimate outcome that we're looking to achieve as we share the care of many individuals. I'm going to go back here for a second to our ecosystem. This is where we left everybody in 2018. And what I'm going to say is, remember, the dotted lines were how people move freely between ecosystems. And this would be my imagined future for behavior analysis as a healthcare discipline, to come out of its niche to, in fact, be a large member of multiple ecosystems with a fuzzy edge so that it can make a contribution across all of these ecosystems. And ultimately, the question becomes, where does behavior analysis fit in these? And I'm going to say, and I would love to lead a workshop to actually drill down. I had initially had details in each of these X's, but I thought it was a little presumptuous for me, not as a behavior analyst, to say where you can make your contribution to each of these functions. But I genuinely believe that there is the opportunity to contribute at all levels, all functional levels of the ecosystem, whether it be, OBM on the administrative side, or, basic science, just like germ theory spurred the evolution of infectious disease. Before we knew there were germs, we couldn't manage infectious disease. Once we understood germ theory, we could manage infectious disease. I think behavior analysis has the opportunity to serve as the foundation for a truly rational approach to behavioral examination, diagnostics, and therapeutics as well as that broader sense of longevity and health status. And in summary, and I want to make sure you've got enough time for some questions, my premise is that the integration of behavior analysis into the healthcare ecosystem is necessary for society and the profession in order for it to fully realize its contribution to the health and well-being of individuals' community and fully realize its potential as a discipline. And in this case, integration into the ecosystem means more than just presence, but full inclusion in and subsequent effect on the functions of the ecosystem. And with that, I'm going to just say thanks and give everybody a second to kind of gather their thoughts and see if we want to do some Q&A.
Yeah, you got it. We have a few questions here for you. So let me see. Let me get my list out. All right. So maybe we'll start with this one. So one of the questions is, how closely are we to outcome-based care? What will the rev up look like?
Well, you know, there's a question, a major question as to what people consider outcomes. You know, when people talk about value-based care, there's 3 levels of value, and honestly, only one counts today. There's value to the patient in terms of their disease burden or functional outcomes. There's value to the professionals in terms of revitalizing their role as professionals. And then there's economic value to payers. And right now, if you look at what is happening in terms of payment reform and the drivers of value-based care, it's all about reducing preventable utilization of services. And this, to me, is a bias that is not necessarily in the best interest of patients. So the question then becomes, what do we consider an outcome? And in the autism community, there are no good outcome measures. You know, we could measure outcomes by asking families, is your life better as a result of the intervention? And by the way, we do this with patients with congestive heart failure. It's not, it's patient-oriented outcomes. It's a real thing. It's well studied. So we're close to outcomes because there's a movement on the value side. At some point in time, sooner than later, we will be able to manage utilization to the point where people are using the most efficient and effective resource. Meaning you don't need to go to the emergency room for condition X. You can go to an urgent care center, or you can go to a primary care provider. And if we are able to route that the right way, then we'll be able to move the value stream to the next level, which to me, the value stream really is, are we looking at the quality of life, quality of health, and people's capacity to succeed in the world on their own terms, which honestly, if you look at the World Health Organization's definition of health, it's overall well-being, not just the absence of disease. Again, I hope that answered the question. It's really hard to do this one-sided. I wish there was an opportunity for some dialogue here.
I know, next year in person.
All right.
We still have another question from Rick. So what healthcare niche do you see ABA as most closely analogous to? And what big trends should ABA pay attention to so it can prosper as a healthcare discipline?
I think first of all, the most important thing is for behavior analysts to start to publish in non-behavior analytic literature. I think you need to demonstrate the connection and build the bridge between the work you're doing. There's some extraordinary, this is one of my favorite books on the planet. It's Henry Rohn and Joel Ringdahl's book on clinical and organizational applications of behavior analysis. There's a chapter in here on medical care problems. There is huge opportunity to say, here's behavior analytic principles. We applied it against this health-related problem. And by the way, remember, health could be behavioral health conditions, health-related behaviors, as well as functional status, activities of daily living. There's tremendous opportunity to publish in the pediatric literature, in the gerontological literature. There's a lot on geriatrics that's been done. So I think that's step one, is to kind of carve out the place. You need to mark your territory in the ecosystem and say, we're a part of this, and the dialogue should not take place without us. In terms of a parallel discipline, I honestly, I don't think there's anything that is so multidisciplinary. Probably nursing would be the closest because it touches every patient at every point in the lifestyle, and also tends to focus more on quality of life issues beyond disease. So I'd make an analogy between behavior analysis and nursing in terms of their disciplinary functions in the ecosystem.
Excellent, excellent. All right, and last question for you. In reference to one of your first slides where ABA can influence healthcare, what licensure will licensure help that dissemination of ABA beyond ASD? Right. Okay.
Yes and no. Licensure is one thing, but the fact is, and again, I'm not being critical here, but the economic pressure on creating more autism-related behavior analysts is actually creating a skew among the professional pool of behavior analysts who are not necessarily comfortable. I'm not saying they're competent. I believe they are competent, but they're not comfortable addressing some of these other issues like anxiety or safety issues, or working with a child with Down syndrome who's got a behavioral disability. And by the way, I don't consider autism itself to be disabling. I think there are autism-related disabilities, but there's plenty of people with autism who are not disabled and are, they're neurotypical and they function in the world their own way. So this is really a matter of, yes, licensure is an element of that, but it's really about understanding scope of practice issues. That's the bigger issue. Scope of practice issues is the bigger issue in the community.
Wonderful. Okay. Great. Well, thank you, everyone. We appreciate your time today. And thank you so much, Dr. Steve, for being with us.
Thank you all for bearing with me. And again, I'm so sorry this couldn't be more interactive. I hope it was helpful. And you all know how to get a hold of me on the app, and I'm happy to take questions privately.
Excellent. All right. Thank you very much, everyone. Have a great day.
Thank you all.